Good evening, everyone. Thank you for coming on this wonderful Thursday evening. Thursday is one of my favorite days in the world because I'm in the OR all day. It's like being in a sandbox. So my wife says, you know, work is work, but at this point when I don't have to go to work, I just go to the OR and that doesn't count. So Thursday's fun. Tonight, we're going to talk about chronic hip pain, which in most cases is arthritis, but we'll talk about a bunch of different things. And even though I'm a surgeon, my name is Eric Johnson, I'm an orthopedic surgeon. I've been in town since about 1996. And so orthopedic surgery, as the name states, deals with surgery, but a large part of what I do is treat people with hip pain. And and most surgeons don't operate on every patient they see. In fact, if they are, they're probably not surgeons very long, or they're doing the wrong thing. So there are ways to manage hip pain or identify things that aren't necessarily arthritis or don't need surgery yet. And more importantly, I think, avoid surgery if possible. If you're doing things right, surgery is the last resort, but you should try, you know, every appropriate non-operative treatment, and that's a lot of what we'll talk about tonight. And a very important part of what we'll also talk about is some of the things from a physical therapy standpoint. We have a therapist also speaking this evening, and whether you need surgery or not, and whether you actually have formal physical therapy or not, having the direction of someone with that type of expertise is critical in managing pain. You know, the take-home points keep moving. So these are some of the things that I hear, that most surgeons hear in the office. Basically, pain starts interfering with your daily activities, interfering with your life. You do things that kind of didn't bother you before, and now they bother you, and you slow down. And if you do that, then it affects everything. So it affects not only how your hip might feel, but it affects how you feel. When you start missing fun stuff, I tell my patients, when you start taking too much fun stuff off your list, then it's time to get moving or do something. And or if you're taking medicines or doing things that worked before and are no longer working, then that's when you find yourself, you know, looking at somebody in an office saying, okay, what do we do here? So if that sounds familiar, you're not alone. About 43 million people have some type of arthritis, and that number is only going to go up, and it's going up because people are wearing out. And believe it or not, I am a baby boomer. I'm the last year. I was born in 1964. So when they talk about baby boomers, before I really knew what that was when I was little, I was like, oh, those are old people. And then all of a sudden I found out I was a baby boomer. And I was like, wait a minute. And now I understand, because I'm 55. But tonight we're going to talk about what causes joint pain. We'll talk a little bit about knees, but this is mostly hips, but a lot of the problems go hand in hand. What you can do, treatment options, what you can do before you need surgery, and that's critically important. But if you do need surgery, what that means, what it involves, what you should do before considering it, or what might prevent you from being able to consider it, and realistic expectations. Again, dating myself, nobody in this room, but we all know who Bo Jackson is. You know, Bo knows, but Bo famously hurt himself playing professional sports, 2 professional sports, had hip replacement surgery, and you know, Bo kept knowing how to do professional sports. Bo's had his hip operated on about 8 times. And so, because those aren't realistic expectations, you know, is to do professional sports on a hip. So we'll talk about that as well. For us mortals, it's actually a great thing, but we'll talk about what mortals do. So a normal hip, you know, is a smooth ball and socket joint made up of healthy cartilage. Your thigh bone and your pelvis make up your hip joint. So people say, my hip hurts. And sometimes people think it's just one bone, when in fact it's 2 bones. Just like saying your knee hurts is your thigh bone and your leg bone. So when someone breaks their hip, you can break either side of your hip joint. But typically you're talking about a thigh bone when you talk about a broken hip. But a normal hip is this nice, smooth, gliding ball and socket. It really does look kind of like a cue ball at the end of your upper end of your thigh bone when you're looking at it. But when you do have hip pain, it can happen for a bunch of reasons. You can have things getting pinched. When that happens, we call that impingement. You can get soft tissue pinched in your hip. You can have a hip that might have been not quite normal in terms of development and lasted you for 35 years, but the reason you have arthritis a little sooner is because it maybe was not quite as round as normal, and we call that dysplasia. So that's why sometimes people a little bit younger get arthritis. AVN is a term that gets thrown out by doctors. Basically, it's the blood supply to your hip can sometimes get disrupted. Interestingly, one of the classic teachings is people who do a lot of scuba diving get the bends. Sometimes that happens to them. It's rare, but if you're in practice long enough, sometimes you see it, and that's what you learn in med school. The most common reason we see it is sometimes in certain medicines or alcoholics. Bursitis, probably the most common thing I see. People try to go to bed, just sleep, and laying on your side hurts. Now it might be arthritis, but sometimes it's just on the outside of your hip and there's a bursa there. You have bursa all over your bodies. They're like shock absorbers and sacs, and they get inflamed. People get it in their shoulders and in their hips and their knees, and that's a very, very common thing. And then arthritis, which is what we're going to talk about a little bit more tonight. So arthritis, instead of that smooth ball and socket joint, it kind of wears down just like the tread on a tire. In this case, that tire is your hip, and the normal smooth gliding surface you see gets a little bit more brittle, wears down over time, and pretty soon you don't have as much cushion, and you start forming what you refer to as bone spurs. We call them osteophytes, but you get little spurs around the joint, and those sometimes click and pop or limit your mobility. So you have difficulty, putting your shoes on, your socks on, cutting your toenails, washing your feet, all those things that are activities of daily living, and that's what we refer to them as, become a little harder, and you feel a little more stiff, and you're not alone. So don't think necessarily you're doing anything wrong if someone has arthritis and they're still working out but they have arthritis. These are things that objectively you notice a little bit more loss of motion. This is just an MRI and a regular X-ray of a hip that doesn't look like a smooth ball and socket joint, and if you look at the picture on the right, that's an MRI, and the real white area is a normal hip, and the darker area is one that has loss of blood flow. And so if you lose blood flow, that's what's supplies, just like plants need water, so your bone needs blood. Even though it's a hard substance, it needs a good blood supply. So if you lose blood supply, it tends to crumble like a foundation on a house. It might crumble and it collapses and is no longer round. So it looks like that on a regular X-ray. And I talked about bursitis. It's a little sac on the outside of your hip that kind of helps things glide over that prominence. So when you're feeling, you put your belt on, go a little lower, that lump on the side of your hips, your bursa. And people have gotten hip pointers, any old football players here, or people who have fallen on a gym floor, or even just fallen and slammed the side of their hip. It's usually that area that hurts. Hopefully you haven't broken a hip, but that bursa is what kind of takes a hit and gets inflamed. And in runners, that same little lump on the side can sometimes, the muscle there, iliotibial band. Sometimes if you go to the gym or talk to a trainer, they talk about your thigh muscles being tight, and the rollers. You see people on rollers now using it's usually trying to stretch out muscles. So the muscles that run down the side of your leg just aren't as tight. They don't snap and hurt, because that too can cause bursitis. And then there's something called a labral tear. And this can cause hip pain. And we're finding more and more about this, not that we didn't know a labrum was there. A labrum's like a little gasket in your hip. So your hip's a ball and socket, but it has a little gasket around the inside that kind of keeps it a little more stable. And sometimes those can tear. Usually you hear people talking about a piece of torn cartilage in their knee or needing a knee scope. Well, this little gasket in your hip can tear too. It's called your labrum. And when that happens, it can snap and pop. And for some people who have a normal X-ray or might have hip pain, this is something that we're finding is more and more the cause of that. And these are a little bit more technical pictures, but suffice it to say, you can also have something called impingement, where rather than a normal shoulder of your hip, you have a ball and socket joint. Normal for you might just be having a little lump on the outside of your hip socket. And again, absolutely normal, the way you were born, nothing you could do about it. But what it means is if you were a computer person and sat and walked, didn't bother you, and never knew it, had 12 grandkids, life was perfect. But if you happen to be someone who did Zumba every night, okay, or 3 nights a week, and then played basketball in college, that abnormality might have caused your hip mechanics to be a little bit different and cause you to have arthritis maybe a little bit earlier, or have arthritis when you might not have had it if you had more of a sedentary lifestyle. So again, not as if something you have to live in fear or walk in eggshells about, but a reason that someone might have that funky hip pain that you just can't figure out. When someone does have some of those little extra lumps or those torn pieces of cartilage deep in their hip, thankfully now we can scope hips. It used to be putting a scope, like we do very commonly in knees, wasn't something we did in hips as commonly. Now it's still a fairly technically demanding procedure, and some doctors are much better and do quite a few more than most of us. I don't do them, for this problem, but it's one way to avoid a major surgery, if that's the reason why you're having hip pain, is getting your hip scoped and getting some of those little pieces of cartilage trimmed up. But the bottom line is arthritis is the most common thing and the most common reason people hurt, and it's why most people end up getting joint replacement surgery. And I always tell my patients, saying arthritis is like saying car. People come in and say, I got arthritis. And I'm like, well, what kind of arthritis you have? Because let's figure it out. Because sometimes the type of arthritis you have or why someone has arthritis is what determines, what the best next step or treatment may be. But there's rheumatoid arthritis, there's something called post-traumatic arthritis. Someone absolutely normal can have a terrible accident that causes their joint, their hip, not to function anymore, or wear out or break. And rather than, medicine or exercise, they actually need a hip replacement. So that's not, unfortunately, as uncommon as you would think. And then I talked a little bit about the AVN, that avascular necrosis. That can be a reason why someone has arthritis. But the most common is good old wear and tear, life catching up with you. And what happens? Well, I'm not telling you anything a lot of you in the audience here probably don't already know. It kind of creeps up on you. You have some pain, some stiffness. Things kind of ease up in the morning. You're doing fine. You kind of loosen up. You might garden. You might go out, do shopping. You might just be moving around the house, feel pretty good. But if it's one of those days, or if the weather's funny, they sometimes are associated with swelling. And simple things just get a little bit more difficult to do. But when a hip does become arthritic, that normal smooth ball and socket joint tends to wear down, and you get some disease on the cartilage itself. So when you have other types of arthritis, rheumatoid arthritis is more of an inflammatory thing, where you get a whole lot of the membranes that line your joint get inflamed, and that inflamed, irritated tissue actually eats away at the cartilage if it's not controlled, or if it's out of control, I should say, or not managed appropriately. So that's what rheumatoid arthritis typically does, and that's why in some cases you don't need to operate on a joint if it's still a pretty good looking joint. It's just some of the medicines that treat rheumatoid arthritis do just that. They treat the symptoms, and people do fine, and possibly, do not need any type of surgical intervention. I alluded to post-traumatic arthritis and avascular necrosis as being, two other reasons why people would have hip pain. Rheumatoid arthritis, again, that's very common, more common in women than men, and it usually starts a little bit earlier than run-of-the-mill osteo wear and tear arthritis, usually somewhere in between 20 and 50. Pain is very, it's a personal thing for obvious reasons. You're the one going through it, and what's painful for some people isn't painful for other people. What some people have to do every day is different than what other people have to do. So we always talk about living with arthritis. Well, some people it's easier to live with arthritis because they don't have to, go to work or don't have to go to a job that is physically demanding, and they can manage it with exercise or swimming every day. Some people have to work every day, and I have quite a few patients who just stand and walk and do labor all day, and that's hard to do if your joints are worn out. It can be in one place, it can kind of radiate. There's something called referred pain. I have a lot of patients who have come to me with terrible, terrible knee pain. Their knees look normal, but you can get referred pain from an arthritic hip that if you get an x-ray of a hip, it looks worn out. Knee looks absolutely fine, but they have knee pain. The opposite's also true. But when it starts interfering with your life, that's when you sometimes end up going to the doctor. So if you do go to see an orthopedic surgeon, you're gonna usually talk to an orthopedic surgeon or a physician's assistant, or hopefully at least an orthopedic surgeon and a medical assistant, and they're going to take I hope a thorough history or have a referral from your primary care doctor that explains why you're there. But most importantly, you're the one who has to explain why are you there. And I try. I'm human. I'm a doctor. So sometimes I admittedly, and I'm not only a doctor, I'm a surgeon, and we're notorious for kind of saying, telling everybody else what to do, right? But I actually try and sit down and say, why are you here? What's going on? And what's your story? But a good physical examination, x-rays, sometimes your primary care doctor might have already taken them, and thankfully today a lot of things are accessible. Just side note, I have insurance too, like a lot of people don't, but I haven't. So you don't want to waste your money, co-pays, everything else. So I'm not one of those doctors who's necessarily offended if someone says, I just got x-rays last week, why do I need them again? Because you get co-pays and a lot of things are electronic, so it's okay to be your own advocate and ask. Now, sometimes there's a reason, and sometimes x-rays are not weight-bearing, so in an orthopedic surgeon's office, they're going to want x-rays usually of you standing up so they can see what your joint looks like when it hurts, when you're actually on it and using it. And that sometimes is not made clear to patients, and I think it's very important that you understand, why you're getting something done, even if it's just an x-ray, because, it's an extra test. So it's okay to ask, and it's okay to be your own advocate, so that's just my feeling. Sometimes patients are afraid to ask, or sometimes people say doctors know best, and we like to think we do, but sometimes we do the easiest thing, that's just to order x-rays, and if someone's already had something done, bring those with you, because they might be very, very useful if they're not 10 years old, or they can be compared, and that can be part of the discussion. So additional tests might be needed, but it's okay to ask why. So when someone does come into the office, make sure you bring your medications, because some medications cause your joints to hurt, or some medications are a key to why you might be hurting. So if someone comes in on a gout medication and has a certain type of pain, even though people famously get gout in their ankles and toes and everything, I've seen gout in hips. If someone comes in on a statin, a cholesterol medication, some of those famously for some people cause a lot of joint aches or muscle aches. And so having a list of medications isn't just something that you do just because you do it. If things are being done correctly, that's information that hopefully is going into a whole counseling process to help figure out the best plan for you. and then any previous diagnoses and your history. So it is important. You know, what do you do? Do you work as a receptionist? Are you a banker? Are you working in an office all day? Are you working as a janitor? You know, what are you doing? What do you like to do recreationally? Do you like to bike? Do you like to run? I have a gentleman who ran marathons endlessly and constantly and set a lot of records, but now he just walks, okay, and had joint replacement, but he's still very fit. But those are all the type of things that go into, you know, helping to formulate a plan. The exam itself basically kind of puts you through the paces. Now, some exams are more rigorous or more involved than others. Sometimes it's pretty clear just watching people walk. I was standing outside here and I watch I'd say 80% of you walk in. So my wife teases me because we go to the mall or the airport and we're sitting around and I'm just sitting there staring at people, wondering what's going on with you know, who had surgery, who didn't, or who needs it. But I get a kick out of just watching people, period. But that's sometimes the most important thing, is just observing. I have to explain to my patients why, you know, my mom actually did teach me manners. I don't help people up, or I watch people get out of chairs and see if they're rocking up or pushing with their arms, because those are all keys to how someone might be functioning when they're not in my office. You ask people, you know, where they live. I don't want to stalk you, but it's important to know whether or not you have, you know, 2 steps or live in a 3-story walk-up apartment, or if you have stairs at home. So those are all things, in addition to an exam, that'll happen, including your strength, range of motion. If you look down at your legs, or I wear glasses, one eye's stronger than the other. Sometimes people say I lead with my right leg. Some people worked as press operators all their life and they have a stronger, you know, they lean on one side more than the other. So you can see not only how someone walks, but if someone has atrophy or a tendency to use one side more than the other. But we look for swelling, all the stuff you always think, reflexes, you know, look at your skin. You know, if someone has a skin condition or psoriatic arthritis, another type of arthritis, it might be something that affects their ability to mobilize. We get x-rays and other tests, but when we do get x-rays, you're looking to see, and this is just a knee, for example, you know, is the joint narrowed down? So just as a hip would be narrow, you look for other joints or other deformities, or if I'm very bow-legged, but you know, I kind of, again, that's what I look for and look at people. So when you look at an arthritic hip, as I alluded to, it just kind of wears down, the tread wears down, and you start seeing some cysts on the side. Now everybody, you know, who gets x-rays and studies, they sometimes get their report, and it reads like a report, okay? And another side note, don't get too freaked out. It's okay to ask, what's this mean? Bring it in, or if you've read your report, it's yours. You deserve to understand it. But radiologists read and note absolutely everything, even if it's not symptomatic, okay? As an example, you know, 40% of adults walking through the mall with no pain in their knees whatsoever are going to have something abnormal on an MRI. But they feel fine. So the same thing's true for a report. So if you get a report that says you have all these funky things on it that don't make sense, it's okay to ask, but don't stay up all night, you know, freaking out about it. So degenerative cysts, subchondral sclerosis, marginal osteophytes, all these things are, you know, the language of medicine, and it can be intimidating. But be your own advocate, get it explained. I'm going to tell you, all that stuff means arthritis. And your hip hurts. Let's talk about your hip arthritis, okay? So, additionally, other things that might be causing hip pain are sometimes diagnosed not just by an exam or x-rays, but can kind of hone in on a diagnosis. Lyme disease, right? It's been a wet season, and we might start seeing a lot of that in the ERs, or it kind of trickles into my office, people with funky pain. And so there are blood tests that oftentimes might be utilized. I sent somebody yesterday to see if they had gout. You know, urine analysis, sometimes if someone really is acting like they have an acute onset of something, then you worry about an infection. That's kind of an orthopedic emergency. But there are other tests like bone scans and MRIs that we oftentimes use to assist in helping someone to make a plan that's best for them. So what do? Exercise, bottom line. Exercise is what I tell everybody to do. You don't have to do what this guy does. I don't do what this guy does. I don't like running anymore. My wife's the runner. I'm the walker and the biker. So I like to hike and bike. But exercise, it can be walking, it can be swimming. Swimming's wonderful. Non-impact activities are best. Activity modification, what's that mean? Well, that means if you used to run, a marathon a month, maybe you pick 4 a year, okay, that you really want to do. Weight management, very, very important, extremely important. And, I'm wearing the white coat, I'm the doctor, it's easy for me to say, yeah, don't do that, don't eat, don't smoke, all that kind of stuff. But biomechanically, okay, 1 pound, your knees, for example, 1 pound equals 5 on your knees, on how you feel. So if someone says, oh, I just gained about 5 pounds over the holidays, and I've done that, it's like carrying around a 25-pound backpack as far as your knees are concerned. So I've had patients who have actually weighed 400 pounds, which is too much, we all agree. And sure, you can tell them what they should weigh, look at the insurance chart and say that their height and weight says they should weigh 193.5 pounds, right? Well, yeah, that's realistic. So that patient, and this is a true story, about 20 years ago, lost about 20 pounds, but it felt like 100 pounds, and it felt a lot better. So then the dominoes started rolling in the right direction. And that patient was able to eventually get down to mid-200s, felt great, never needed surgery, okay? Because it was just that little bit of change. So biomechanically, okay, the physics around weight is not just, doctors saying lose weight. It's less stress on your joint. So even with a worn out joint or a joint that isn't 16 years old, if the surrounding structures, and that's where a therapist is going to talk to us, are strong and limber, and if you're not putting abnormal or excess stress on it, you can feel a lot better and sometimes not need surgery. So weight management's key. NSAIDs, over the counter, okay? I'm not a big pill person. I don't like to take pills. I don't like to give pills, but the reality is an occasional anti-inflammatory works. And if it's one of those days, and if it's weed season, so if you're out picking weeds all weekend, something's going to hurt, and it's okay to take an occasional anti-inflammatory. But I tell people to do that long term under the direction of their doctor, their primary care doctor, because it's important to get your labs checked every year and a half, because all this medicine gets filtered by something, and it's your kidney or your liver. And if other medicines are overloading your kidney or liver, or if you drink a little too much, or if you have a history of cirrhosis or diabetes, then even over-the-counter medicines taken in excess can cause problems that you really don't want to deal with. But they're around because they're good, and it's what most orthopedic surgeons will recommend. And we're talking about things like Tylenol, an Advil, and Aleve, and you have a hand up. Yes? NSAIDs, yeah?
Do they degenerate cartilage?
No, they don't really degenerate cartilage. No. What does degenerate cartilage, now I'll talk to you about that, is steroids in excess, okay? Injections, too many injections. But we'll touch on that. Canes are great. If you don't want a cane, get a trekking pole. That's hip, makes you look like a hip person out hiking. I have them, okay? So when I go out hiking, and I love to hike, I sometimes use trekking poles. I used to use them because I had a kid in a backpack, when they were little, and they were heavy. Now they can carry me because they're in college. I tell them they have to. But I still use trekking poles because they help you, they take the load off, and they help you walk a little further and get outside and enjoy the outdoors. So canes are fine, and they're signs of intelligence and not weakness, okay? They keep you from falling, they let you go a little further safely, and I can guarantee you nobody goes home at night and says, do you know what I saw? I saw this lady with a cane today. Man, nobody's saying that. You think they are, okay? They're not saying that. So it's okay to use assisted devices. Braces, for the right reason, help. Some of the real fancy, things you see on TV, will do the paperwork for you, fill out the brace, government fraud. I wouldn't know. You were talking about like knee sleeves that give a little compression. They help so-called body awareness, and we call it proprioception in medicine, but when you step down and trust that that step's there for you, sometimes having your knee hugged or your hip hugged, that helps, but there's no real brace for a hip, all right? And so, there's not a lot to do about bracing a hip. The main thing to do is be limber and strong, but most of what you hear, about braces is usually for knee braces, and that's a whole other talk. So PT, scoping a knee, cleaning out a joint in a knee, you can sometimes do it for a hip for the right reasons. There are joint fluid supplements called viscose supplements. You might have heard them called gel injections or chicken juice or that kind of thing. They're not used as frequently. Injections are not used as frequently for hips, partly because they're not approved, partly because they're not as effective, mostly because they're not as effective. So from time to time, it is appropriate to use one of these viscose supplements and gel injections in a hip, but again, the biomechanics and the nature of a hip joint doesn't lend itself to injecting and having it be as effective as you think. It is something to consider, and I ask your doctor about if surgery's not the right, it's either not the right time or you're not able to get it. Yeah. Cortisone injections, like I was going to say, cortisone injections also not real. I used to use them a lot more. Not real effective in a joint, but still something based on a conversation, a clear understanding of your particular situation, can be effective and can work for a long time. There are some types of steroid type injections. Cortisone is a steroid. What I would warn and tell everybody is steroid injections in a single joint are fine and safe and can be very effective, but too many do soften your bone. And that's why most doctors won't recommend any more than 2 a year, okay, 2, maybe 3 a year. Depends on the doctor, depends on the type of practice, rheumatologist versus an orthopedic surgeon versus, sports doctor. But I always tell my patients that, this is not the NFL. So if your hip wears out, it's not like you're going to get your hip replaced when you're 32 and your NFL career is over, and that's what happens. But, we're not putting you back in the game for your, $20 million a year. You're getting better so you can, pay your mortgage and go to work. But joint replacement is last on the list here, and again, should appropriately be last on most people's lists. Somebody asked about supplements. They're all out there. None of them are clinically or scientifically proven to be effective, but if somebody's on them and they help, and they seem to help, you might be the person they help. So I don't tell people to stop them if they're on them and they seem to be working, but it's not something that I'll tell anybody to really start, okay? And that's based on literature. And I'm someone who, early in my career, first seven years or so, glucosamine chondroitin actually was studied in the orthopedic literature, and there were some studies that favored it. And in certain countries and still used pretty frequently. But then they came out with a meta-analysis, which is basically a type of study where they take all the studies, it's thousands and thousands, they look at the literature very critically and came out with a recommendation that says it probably doesn't work, but if it works for your patients, or and I actually had myself on it for a while, and I ran out. I didn't get to Costco for a month, and I said, well, I don't feel much different, so I'm not going to keep there. So we talked about, yes, ma'am. Turmeric is an anti-inflammatory, so it's a natural anti-inflammatory. And so I have a lot of patients who are on it. Make sure that with a lot of the herbals, I'm not a herbalist or a naturalist, but I always tell people to, if you're going that route, that's perfect, because people have been staying away from doctors and living a long time, for millennia, taking things like turmeric or certain diets. But I think you have to be all in. You have to be in that type of society and that type of diet and that type of lifestyle. It's not as if you can live like an American, take turmeric, and then life's wonderful. So they all kind of go together. And more importantly, if you're on other medicines, some of the either GNC supplements, turmeric, some of the other natural things do interact. And so, okay to take them, and some doctors recommend, those instead of medicines. It's just, it needs to be done, in a coordinated fashion, so you're not, but turmeric is a good anti-inflammatory. So physical therapy, I don't want to steal any thunder here, but basically getting range of motion, reducing stiffness, keeping your joints flexible, finding a non-impact way to do that, whether it's walking, biking, swimming, elliptical trainer, yoga, tai chi, things, and those have been actually, tai chi, Pilates, yoga, in the orthopedic literature, absolutely recommended, along with swimming, and absolutely recommended. Not that you have to go to physical therapy indefinitely, okay? That's not the key. An appropriately directed exercise program. Usually what I do is write for somebody to get a visit to a therapist and get on track. And if you already join it in a gym, then you take that exercise and you make it your own. And if you need, boot camp every 2 years, and you go to a therapist again to kind of re-up, okay, just to get homework or modify things. But getting the right type of exercise. If you go to Planet Fitness and do the loop and the circuit and do every machine just like the 18-year-old in front of you, then you're going to be seeing me for other reasons. So it's important to do the right type of exercise. You don't have to do every machine. You don't have to do you don't do it every day. And for those of us who, in our past or even now work out, you don't work out heavy every day. Again, I don't want to get into too much of what the physical therapist is going to tell us. So the reality is you got to get moving. And this says, will I still be able to not exercise? This is what the guy's asking this doctor. He's writing a prescription for him. He said, this is great, this is going to work. Do I still have to exercise? And you got to get moving, okay? So when you do make the decision for surgery, this is you've done everything appropriately, non-operatively, you're having pain, your quality of life suffering. Hopefully you're not falling, but I point blank ask a patient who comes into me, have you fallen? And if they say, yeah, I fell twice last week, or I'm falling about once or twice a week, then that's kind of a red flag, okay? If someone tripped over, their grandchild's Legos, that just kind of happens. But we talked a little bit about, when you do have surgery, arthroscopy, osteotomy is when you cut a bone. So there are some very specialized procedures where someone might wear out in a very selected area, and you can cut the bone and line up the part that isn't worn out to a different position so that it's taking the load. It's kind of beyond this talk, but it's more of a specialized procedure, and believe me, if that was necessary, that's a whole different conversation. But in extreme cases, you can fuse hips. We don't have to fuse hips like we used to. It used to be a good procedure for somebody who was high demand and had a terrible hip. You just fuse their hip and they'd limp, but it'd hold up. But with the advent of some of the newer prostheses and they're lasting longer, we don't really fuse hips like we used to. Now when you get a hip replacement or hip surgery, for most people in this room, if they were to need it, and in the vast majority of people, we're talking about a hip replacement, a total hip replacement, where you replace the arthritic part with a smooth gliding part, and most times you replace both the cup side and the socket and the ball side. In some cases, if people are very low demand and happen to, have bad arthritis or break their hip, sometimes you just have to replace the ball, and that's enough to keep someone moving at a low level or a low demand level, and it's less surgery, less stress. But for the most part, an artificial joint's designed to move and replicate, a healthy, normal joint and allow you to do most, normal activities. So I had a patient yesterday come in for their follow-up visit. She had her hip done few months ago, and her husband want to go kayaking, next in May, June, and that's fine. So, she's not jet skiing or water skiing, but, she wants to go out and kayak. And so you do these things to live your life. But when your pain is severe, you can't live your life, and you can't work, then you gotta make that decision. So it's usually something that you're thinking, but talk to your doctor, because oftentimes your doctor, your primary care doctor, might tell you everything I've just told you. Here are all the non-operative treatments that we should try, or this is what you should do, or they might send you to a therapist, or they might tell you to try an exercise program, and you might do those things and lose 15 pounds and feel wonderful and never have to see an orthopedic surgeon. But if it comes down to that, then we talk, okay? But when you do get a hip, it's actually a pretty straightforward procedure nowadays, and it's reproducibly quite effective in the vast majority of patients. We are very lucky. I'm not tooting my own horn here. I think I'm part of this community and part of this, part of Trochanteric Care. We're very lucky. The standard of care in this community for medicine is high. And I'm an Army brat. I moved around growing up, and I have a lot of friends all over the country. It's a really, really good place to live, and the standard of healthcare in this community, okay, is very high. A lot of people working here every day, doing everything from family practice to OB-GYN and orthopedic surgery, could go anywhere. And I think we're lucky to have the resources we do. So some places you have to doctor shop or drive, 2 hours to get to somebody who knows what they're doing. The nice part is the Joint Replacement Center at Christian is, and I'm, I don't have any ownership or interest in I'll get paid to say this. I work here, but I don't. And yeah, I have interest because I'm interested in my workplace being real good, and it is. But the point I'm trying to make is, you don't want to doubt, the care you're getting. And I feel proud to work in this community because of the support that I get from colleagues and institutions. And I'd like everybody here to feel confident that that's, your health is in everyone's, it's in the front of their mind, okay? And it's okay to ask questions. It's okay to get opinions. I'm not one of those doctors who gets mad if someone needs an additional opinion, but I feel obligated to say that the doctors who work here do their surgeries in this community. And we're all part of training programs, so we all had to learn somewhere. So it's okay to ask if you go to Jefferson or Penn or anywhere, okay, who's doing my surgery, okay? And make sure that that's a question that you ask, okay? And in most cases, even if a resident's there, it's going to be done very, very, very well, and the attending will be there. But I'm saying this, I'm getting a little off track, but it's important because it's not something that people think about, and you shouldn't have to worry about, but you need to hear it from a surgeon that it's okay to ask, are you doing my surgery, and have you done these? Is this something you're good at? And if people get offended, then you're looking out for yourself, okay? It's okay. Sorry about that. I'm a little passionate about patient advocacy. So if you can't get better with non-operative treatment, you end up getting a joint replacement. We talked about all the preoperative stuff. Let's talk about the hip joint and what it looks like on the inside. So a hip replacement is, as I said, a ball and socket joint, but you're replacing it with a artificial ball and socket. So your thigh bone is like a ham bone. It's hollow, and you can kind of core it out and put a new stem in there that holds a ball that rotates in a socket. Now this is what you hear about on TV. Do you have this hip? Do you have that? And most hips in America There was a metal-on-metal hip that was a problem for a while, but most hips now have a new polyethylene, the plastic liner, the white liner you see here, that is 99 times stronger than what was being put in when I started in practice in 1996. And that was kind of the Achilles heel of hips, not the mixed body parts. But that's what kind of wore out and caused the hip to loosen. But that because that's gotten to be pretty darn strong, and because we don't use bone cement anymore, the surface you see on this, which is usually stainless steel or titanium now, your bone grows into this surface and it grows into the backside of the cup. So rather than bone cement, which can loosen and isn't a biological substance, your own bone socks it in. So that's why it's so important to be healthy and have good bone and not smoke. So things that can affect bone health are smoking significantly and kind of make things loosen sooner. But this is what a hip replacement looks like, okay? So you cut away the part that's worn out and you put in a smooth gliding ball and socket, and just to switch back and forth, not to make you dizzy. But that's what goes in there. So recovery, okay? You get up right away with hips now, all right? So you get up the same day, and in a lot of places, even in Delaware, it's a same-day procedure. It can be, doesn't have to be. But in some cases, if you're otherwise motivated, healthy, feeling pretty good, a lot of people get up and want to go. Most people stay in the hospital 1 or 2 nights, usually 1. The length of stay in Trochanteric Care's Joint Replacement Center is about 1.1 days. So most people get up in therapy the same day and leave the next morning. Recovery is very individual. Again, it's 1 or 2 days on average. But people rightfully say, when's it going to be better? When's it feel normal? And everybody's normal is different. If someone's going back to work in a grocery store, that's going to be about 12 weeks. If someone's going back to, drive their grandkids to school or play golf, that might be 6 weeks. Until you're not really thinking about your hip, it's 4 months, and you get stronger. If you do your exercises, you get stronger. Therapy is something we do routinely, but a lot of places, once you're on track, you can check in with your therapist. In some places, it's virtual. You do it with a computer program. Sometimes it's online. In most cases, it's outpatient. Starts off usually about 3 days a week, tapers down to twice a week, anywhere from 2 weeks to 6 weeks. That's a busy slide. You want to get back to your routine. You start doing stairs in the hospital. So patients often say, am I going to be able to go up and down stairs? And my answer is you're going to do stairs better than you did the day before surgery because it's not going to hurt. Now you're going to take them slow and easy, but you did that the day before your surgery. So we actually do make people, test themselves on stairs, and you really shouldn't have that many restrictions leaving your home. We try to get people out and moving. And we talk about hip restrictions. We don't want you doing any, deep, heavy squats, weighted squats now. You can still do most activities. If someone is a heavy weightlifter and does deep squats, I say don't do that. Some types of construction work or carpentry, which are a little heavy demand or get you in odd positions, probably not the smartest thing to do, but usually by the time someone comes to the point where they need hip replacement, they're not doing that type of work anyway, and returning to it in more of a supervisory role is what I recommend. You do have some limitations. Again, high impact sports, full court basketball, you can shoot around, you can play doubles tennis. Yeah. I have patients who do ski, but they learned to ski when they were 2.5, but I don't tell them, oh, now my hip doesn't hurt, I always wanted to learn how to ski. That's not the time to learn. You tell them they're never going to ski. But I do have patients who have skied all their life, and I let them go back to doing that type of thing. But yeah, your expectations need to be realistic. And if you take care of it like anything else, it's going to last longer. So just having realistic expectations about how old you are. And if someone's 55 and unfortunately might have needed a hip a little bit sooner, I say really take care of it. Now is the time to stop running and start walking and hiking and biking or swimming, not beating it up so you wear this thing out. If someone's 85 and needs a hip, I tend to think that if you made it to 85, you don't need me to tell you what to do, but just be smart and let's have this thing last forever. That's really it. I'm going to I've been talking long enough here. So.
All right, guys, so I'm just going to take a few moments here at the end to talk about how we, in physical therapy, manage hip pain. And then, depending on time and such, we'll take questions for both of us towards the end so we can get this done and get you guys out of here in a timely manner. So, I'm just going to spend a little bit of time telling you about me, and then a lot of time telling you about you. So I grew up on the Eastern Shore of Maryland. This is the first question pretty much all my patients ask me, are you a Delawarean? And I have to say no. But I started working in the field of PT in 2006. I'm a University of Delaware alumni, so I kind of am a Delawarean. At least I like to think so. I spent a year in private practice, but for the last 4 years, I've been working for Christianacare on Folk Road. And I did a little bit of rotations at the Center of Rehabilitation at Wilmington Hospital as well. My favorite job is being a mom. So you're going to understand the anatomy and how I can impact your anatomy. We're going to talk about the role of PT in managing chronic hip pain when considering a total hip replacement or just trying to manage it without it, and understand a little bit about what PT does for you after you have surgery, if that's the case that you have to go. So, hip anatomy, structures that we can impact in the world of PT. We can impact the joint. In the conservative world, we really want to impact the joint itself. We want to make it as mobile as we can. We want to make you as flexible as you can. I always tell my patients, we're going to lengthen before we strengthen. We want to make sure that you have full range of motion or as much motion as we can get back before we try to strengthen, because if we strengthen this short range of motion, you're only going to be strong when you're sitting in a chair, but not when you're getting out of the chair. You're only going to be strong standing up, but you're not going to be strong when you're trying to pull your weeds. We can impact the muscles themselves. We want to make them as strong as we can. We know for a fact, I could give you probably a list of 100 patients who've come through our office who we saw before surgery, or who say, oh, before surgery I went to the Y and I did the arthritic aquatics class, or I've been working out with a personal trainer, or I've been going to the gym, or I'm a hiker, I'm a biker, I'm a swimmer. Those people do way better after surgery than those who have led a pretty sedentary life or who haven't been able to do anything for a long period of time. We can address the tendons. Sometimes we'll see patients come into our practice with pain in their hip and they'll be like, I think I have arthritis. And their joint will look fine on x-ray, but they'll have some tendon irritation on the side of their hip. So we can sometimes address that a little bit. And then the bursa, we can address the bursa and bursitis. We can lengthen the muscles around that bursa to decrease the pain. But more importantly, we can strengthen that muscle that surrounds that bursa so that you don't have as much irritation to it when you're doing things like moving around, getting up and down, walking. So what I like to call prehab is anytime I'm treating someone and our main goal is to prevent you to going into the operating room. And so the prehab is a big thing that we're starting to see happen a lot more often as people are living longer and they want to prevent having to have surgery early on in life, depending on how active or what kind of activities they did. But also it's a big thing that we're seeing because we're seeing that it is impacting the outcomes of our surgery, and we're seeing our patients who have surgery get back to doing the things they love and want to do faster. So in prehab, our main goal is to increase your range of motion. How much can your hip move? And we want to make sure you're as strong as you can be. And this is not just how strong is your hip, that's one thing, the muscles surrounding your hip, there's a lot of them, but also how strong is your knee? How strong is your core? How strong is your back? We always look at the joints above and below the body part in question. And so we spend a lot of time working on that with our patients, especially those who want to get back to things like golfing and tennis in a pain-free way. We want to make sure that we are giving them the strongest base that we can. Things we can do, so I can do some hands-on techniques. I can do things like mobilize the joint. I can do things like mobilize the soft tissue, the muscles. Sometimes the muscles are overworked and they're in spasm, which might be something you've heard before. They're just really tight. So we can mobilize the soft tissue. We can stretch the muscles, we can stretch the joint capsule in and of itself, but none of this is going to heal you. I tell my patients I would love to be the magical person who could come in and put my hands on you and be like, you're healed. It doesn't work that way. As Dr. Johnson alluded to, the way people get better, and we know this to be true, is through exercise. But these are the things that we can do to help you so that you can do exercise with less pain and do them more effectively. So when we're doing exercises, we're focusing on similar things. We're focusing on range of motion and strength. We'll give you a grouping of exercises, of stretches that we'll want you to do pretty regularly. These are things that I call the brushing your teeth of the hip, or the brushing your teeth of your knee. You brush your teeth every day, or most days as long as you remember, and sometimes twice a day. And you do that so that you don't get cavities. Well, you need to do these stretching exercises so that you can keep your hip as functional as you can, so that you can stay away from the bigger and scarier world out there. So we'll give you some self-stretching, do you some active range of motion exercises, and these are the things I tell people, it's gonna take you 5 minutes, you can do them lying in your bed, but do them every day and you will feel better. And then we also focus on hip and leg strength. Those are the things you only have to do a couple times a week. They're the heavy lifting or the heavy work of the exercise world. And typically I tell patients, here's 5 exercises. You can choose to do all of them at the same time every couple of days, or you can choose to do one of them every day and just keep rotating through them. But at the bare minimum, you need to be doing something for the strength of your hip and your legs. So we'll strengthen the glutes. Those are the big muscles that surround the hip. And then we also do a lot of quadriceps strengthening. That's the big thigh muscle in the front. So a lot of times we find in the research in the PT world that quad weakness and glute weakness go hand in hand. And a lot of times after the hip replacement, if the hip's better, they still can't go up and down stairs. They still can't get up and down out of a chair. When we go to look at their quadriceps strength, they only have 50% on the side of the surgery. And so until that strength comes back, they still continue to have that hard trouble. It's not painful. It feels good, it's just really hard still to do. And the goal is to keep everything pain-free but effective. The last thing we want to do when you're coming to see us is to create more pain. You're coming to us because you have pain. So we keep everything pain-free, but we keep it effective. We find ways that you individually can do what we need you to do to get stronger, to get more flexible, but not to have any pain. We also use modalities. These are things that you can use at home or we can use in the office. Heat or cold, it doesn't matter. It doesn't. Not beforehand. They do the same thing, whatever makes you feel good. There was a big discussion for a while that heat caused more inflammation. It doesn't get deep enough to inflame the area of the question, but if it makes you feel better, then use it. We can use electrical stimulation, different protocols, different ways that we can use it to help control pain. It's all temporary, but if it temporarily means that you can do something fun or do something that you need to be able to do, then we will use it. And this is something we could have a whole discussion on, but dry needling, it's something that we utilize in very specific cases for very specific things, and it's a modality out there that we can utilize. So that's everything we can do for you beforehand, but what does it look like afterwards? I think this is something that it's pretty easy, it's pretty straightforward, it's pretty streamlined anymore. The surgery has gotten to the point where it's pretty streamlined, and so is the rehab, and you can talk to your friends, you can talk to everyone, and they can tell you, oh, I did this, I do that, I did this, I do that, but you are your own individual person, and it'll take your body as long as your body needs to get better. But this is typically kind of how it looks. So in the hospital, you have approximately 3 sessions. You'll have a morning and afternoon session. So depending on what time your surgery was, will depend on how many you get the first day, and what time you go home will determine how many you get the second day. But it's about 3 sessions that you end up getting in the hospital. We work on things. You do some group exercises, some things that you'll get in a handout, things that you'll go home doing. But then you'll have some individualized time that'll focus on making sure that you're walking appropriately, making sure that you're using your new hip to its full advantage. It's new, it's perfect, it's better than it ever has been in a really long time. So you want to make sure that you use it appropriately. Work on things like stairs. You're going up and down the stairs that day 1. Things like curbs, Going up and down curbs, this is important if you have a front step but no handrail. Got to know how to do that to get back into your house. And getting in out of bed, getting out of the car, getting in and out of the chair, these are things that are important and things that you can do on day one, and we want to make sure that you're doing them right from the beginning. And then we spend a lot of time educating our patients on what to expect. You spend a really short period of time in the hospital, and so we want to make sure that you leave us with no questions, and that you're ready when you go home to have the best care that you need. Occasionally you'll have a home PT or a rehab stay. This depends on circumstances. It still does happen. It doesn't happen as often anymore, but most people will come right to see me in the outpatient world, and or will just communicate with a therapist virtually or not at all, depending on what their goals are and how they're feeling. So yeah, some patients will have 3 to 5 days at the home therapist, but most time they'll come to me. Home therapist just works on the same things. Home safety is the biggest one. If you're living alone, we work on making sure that your house is set up and ample and ready for you to be there safely. We'll continue to work on walking, progressing your exercises until you come into the office to see an outpatient therapist, and continue to educate you. Outpatient world, which is what I know the best. We have a pathway that we have developed in the world of PT. It was developed by a group of physical therapists and then also a group of doctors who have looked at it and approved it, and it takes you through step by step. So it's not, this is what you do week 1, this is what you do week 2. It says, this is what you do when you've hit this goal. This is what you've done when you've hit these goals. This is what you do when your goal is this. This is what you do when your goal is that. So if you need to get back to working and you have a job where you're sitting most of the day, and then your goal is just to be able to do an occasional walk, your goals are going to look different than someone who wants to get back to playing doubles tennis, which is what I see a lot in my office, and those who want to get back to running with their grandkids. A big question I hear all the time is, can I get on the floor and play with my grandkids, and when can I do that? I had a patient just the other day who I spent 15 minutes practicing with a dumbbell weight of 15 pounds, which is the weight of her 2-month-old grandbaby, walking around because that's what she wanted to do, so that's what we did. So everybody's rehab looks a little different, and it's all based on your goals. But we use milestones to help progress you through each stage. We want to make sure that you have the right amount of strength, the right amount of range of motion, and that most importantly, you're safe. Treatment is guided by the pathway, but all treatment plans are individualized. If you don't have a 15-pound, 2-month grandbaby, I won't make you carry the dumbbell around my clinic. But if you want to get back to doing doubles tennis, we had a guy in the clinic just the other day. His goal is to get back to playing tennis. He was in the office doing quick motions, side to side, front to back, hitting his racket. Not day 1 or 2 out of surgery, but he was in our office until he could get back to playing doubles tennis. I had the same cute little lady, and she said, I just need to be able to get out of my chair, get to the bathroom, and get back to my chair so I can watch my TV shows. As soon as she could do that, she left my office. That's all she wanted to be able to do. So that comes to discharge. What is a typical treatment course? This is what I hear all the time. First thing they want to know when they come into my office is, how long am I going to be here? And that's totally individualized. Typically, what we'll see people for, we'll see people 2 times a week, sometimes 3 times a week early on, just depends on what your goal is, depends on how you are hitting your milestones, if you're living alone, if you're living with someone, how much family support you have, and most importantly, how good of a patient you are. I had a patient come in the other day and she said, I'm a really bad patient. I said, what does that mean? She said, I'm not going to do anything you tell me to do. And I said, okay, and I'm going to see you 3 times a week until you're better. But then I had someone who said, look, I drive, I'm all over the place, I'm never here. Can I just come in once a week for an updated exercise prescription? And that's totally fine too. Typically, we see you anywhere from 4 to 6 weeks. Just depends on, again, how you're progressing and what your goals are. We'll see people longer than that, and I've seen people shorter than that. I've seen people come into my office 3 days out of surgery, and we get rid of all of their assistive devices. They're walking around just fine, no walker, no cane, and in 2 weeks, they're out my door. But then I have people who will use a walker for 4 or 6 weeks, and they spend a little bit more time with me. It doesn't matter. You're each your individual person. You're going to do what's best for you. We'll do more or less, again, depending on how you progress. But at discharge, most people are discharged at about 70 to 90% of their baseline function. So that means you're able to do most of everything that you want to be able to do. And the rest of that just comes with time. The surgeries are great. Unfortunately, they're not going to get any better, I think, until we speed up healing time. The body just heals a certain speed. And that's something that we can't impact greatly, but with time you will get there. Healing continues and changes and improvements happen up to 1 year and beyond. I see people come back into my office for other ailments or just to stop by and say hi, which is a lot more fun. And everyone at about 1 year says, I don't even know which hip I had replaced. I can't remember. And that's my goal for you, is at the end of the day, you don't remember which hip you had replaced or which knee you had replaced, and that it's just part of you and you're back to doing things that are fun. So, managing chronic hip pain, it's doable. It's individualized. It's based on you and your body. But it requires a team approach. I can't manage it on my own. Dr. Johnson can't manage it on his own. And you can't manage it on your own. You need the help of resources around you, and I encourage you to use those resources. And it happens in stages. There are people I see come into my office. They're thinking they're going to have a hip replacement. We do some therapy. And then they don't get their hip done for 5, 6, 7, sometimes never years later. And it happens in stages. Sometimes, like Dr. Johnson alluded to, you'll come in, you'll get your hard, fast, this is boot camp, this is what you're going to do, and you're going to go do it in the community. And then you have to come back in 2 years because you had your holiday 5 pounds, or you got lazy, or something happened, life happens, and you just need an update. So it happens in stages, and happens for everyone. So, thank you.